This is Andrea Kane, and I'm here with HIT 330, Health Information Technology. And we are looking at Chapter 3, Health Information Functions, Purpose, and Users. This is the first of two lectures for week number 8. The first one will cover Chapter 3. The next one will cover Chapter 4. So this one is for Chapter 3. And if you are looking at your syllabus, we will be covering Unit Objectives 9.4.1 through 9.4.9 and 9.8.1 through 9.8.6 this week. Okay, so we're going to talk about the who, what, when, why, and how of patient care, data, information, and knowledge. The primary purposes of the health record are patient care, management of that patient care, and administrative processes. So the first purpose of the health record is patient care. I want to emphasize that. Patient care. That is what it should be about. The secondary purposes have to do with education, legal accreditation, and policy development, as well as public health and research. So a secondary purpose that you want to keep in mind is that public health, research, education, legal accreditation. These are not direct patient care things, they are secondary. So if you go back to the first one, everything is all related to patient care. Secondary purposes is things that are not direct patient care but do have an impact on it. Formats of the health record. You have paper health records, electronic health records, and hybrid health records. I will tell you that in reality, almost everything is electronic these days. There are very few paper health records, still out there, and even fewer hybrids. Hybrid is typically someone that's in the middle. They have paper records, they're converting to an electronic health record, and for a period of time in the middle, they have sort of a half and half situation going on. Having been there and done all three types, the hybrid is the hardest to manage. Primary users are healthcare providers. They are the ones who typically use the record the most. And they are looking at the patient record, they're looking at aggregated data, they're oftentimes in need of de-identified information. Individual users include patient care providers, patient care managers and support staff, coding and billing staff, patients, employers, lawyers, law enforcement officials, healthcare researchers, and clinical investigators, as well as government policymakers. Institutional users include healthcare delivery organizations, third-party payers, medical review organizations, research organizations, educational organizations, accreditation organizations, government licensing agencies, and policy-making bodies. If you are not sure what these mean when they're talking about these different users, please make sure that you look those up. Check your book first and see if it's there. Check the index of your book in the back and see if the information's there. If it's not there, then Google it. Make sure that you're familiar with what all these are. So, medical transcription and voice recognition. Transcription is taking a voice file and turning it from voice into basically a document, whether that's electronic or paper. Medical transcription has been in-house or outsourced. Most all organizations now outsource their transcription. Very few keep it in-house. I have done both, so I'm familiar with both. It can be great in-house, it can be great outsourced. It really just depends on the people that you're utilizing, the company that you're utilizing, and the relationship that you have with them. And also with your providers who are doing the dictation and the systems that you use. Voice recognition is either front end or back end. I'm kind of skipping ahead here, but it's either front end or back end. On the front end, the person that is dictating it makes the edits. It comes up on the screen as they speak the words, and then they make the edits, they make the changes, they review it, and then they electronically sign off on it. That is front end speech recognition with a, Back end is where they've they've dictated the report, and it goes through a processor, a natural language processor, and whoever's on the back end then sees the completed document and goes through and edits it. So that's the difference between front end and back end. Documents get transcribed. Typical documents you might see are the history and physical report, discharge summary reports, consultation reports, operative reports, progress notes. Those are the types of reports that you will see dictated and transcribed, or going through a speech recognition process. Release of information, that is disclosing patient identifiable information. You have probably heard about HIPAA, H-I-P-A-A. Remember, HIPAA only has one P, not two. Release of information is receiving requests for information and making sure that those requests are appropriate, and then providing the information that has been requested. Again, this can be either in-house or it can be outsourced. I have lived with both. It can be great or it can be terrible. Either way, again, it comes down to people, relationships, and processes and technology. You may have a supervisor with that. I'm going to go back. I kind of skipped over the transcription supervisor. Whoever's fulfilling that kind of role is looking at the quality of the reports and the timeliness, making sure the turnaround times are as speedy as possible. The ROI supervisor is also monitoring quality, making sure that the right information was released and only what was minimally necessary to fulfill the request, and that we had a patient authorization if it was needed, and that it was a valid authorization, those types of things. And then turnaround time, making sure that the information reached the appropriate requester within a reasonable period of time. Clinical coding and reimbursement. Coding, if you haven't been exposed to this yet, although I think you are probably taking a class this semester perhaps, if not this semester, next semester. Shelley Grant tends to teach those, and she does a great job, and she will tell you what coding is. It's essentially taking diagnoses and procedures and turning them from words into codes that can then be submitted for billing. Abstracting is pulling out specific pieces of data and entering those so that they can be utilized for reporting and databases and other things. And then billing is where you actually take the coded information, it's put into the appropriate format, if that's an electronic bill or if it's a paper bill, and then it's submitted. You make sure that that everything is completed the way that it should be completed, and then it's sent off to the payer for reimbursement. A coding supervisor is definitely looking at quality, and really not just of the codes. They also look at timeliness or coder productivity and things like that, making sure that accounts are getting coded as they need to be, so that you don't have an increase in what's called DNFB, and that's discharges not yet final billed. All right, record storage and retrieval. That is, storage and retrieval is primarily used now with paper records and with microfilm, microfiche. Once you go to electronic, your storage is all part of the EHR, and that's maintained by IT. So that's the difference. And when it goes electronic, there's typically a document management system involved, and the storage of that. And again, that's through IT. A hybrid health record, you're storing a paper part, but you also have the electronic piece to manage. Master Patient Index, or the MPI, is a permanent record of all patients that are treated at the healthcare organization. It includes their demographic information. It is also used in a numeric filing system, and it is part of an enterprise master patient index if the healthcare organization has multiple MPIs. For instance, if there is a healthcare system that owns 3 different hospitals, each of those hospitals may have their own master patient index. And so if you as a patient have been to each of those 3 hospitals, you have a different medical record number, but they're all owned by the same corporation. So they typically then give you an enterprise master patient index number, or you're in their enterprise MPI, the eMPI, and you have a number, and that number links all of your medical record numbers or those master patient index entries at each of those 3 other hospitals so that they can identify you no matter where you go. So the EMPI, the things that they recommend be included in that include all of these things on this nice little slide here. So feel free to review all of those. Quality issues in MPI systems. Oh, mercy, there are lots. Anytime that you try and merge an MPI or create an EMPI, you definitely find issues. There can be typographical errors, outdated demographic information, incorrect names, incorrect date of birth, incorrect social security numbers. You can have duplicates where you can have the same person having 2 or 3 medical record numbers in the same NPI. You can have an overlay where somebody thought Jane Smith at Hospital A was the same as Jane Smith at Hospital B, except they weren't, and they merged them together, and that created an overlay. Or, for instance, you have 2 that come in to the same hospital, and they get registered differently instead of to the same medical record number. So you've got somebody that has 2 separate medical record numbers, and then, I'm sorry, let me back up with that. An overlay is where you basically take 2 different people, maybe Jane Smith and Jane Smith, except that one has the middle initial of A and the other one has a middle initial of H, and they're 2 totally different people, but they get merged into one, and that's an overlay. And then there's something called an overlap too. So I would send you back to your book to really look at duplicates, overlays, and overlaps if you have any questions about those. Algorithms. There are 3 types of algorithms that you'll run across: deterministic, probabilistic, and rules-based. And I'm going to also return you to your book to talk about those. Paper-based filing systems. There are different ways that you can file paper-based records. And a lot of it depends on what kind of a facility or organization you are. You can file records alphabetically, but it's recommended that you don't do that unless you're a small physician practice. You can file them numerically. It can be a straight numeric system, a terminal digit system, an alphanumeric system, or you can use what's called middle digit as well. That's terminal digit. Of those, terminal digit is the most common that you will run across, but there are all of that, and then you can use a centralized unit number as well. Paper-based storage is there are filing cabinets. There are also shelving units. You can have open shelving units, or you can have what's called compressible. We call them mechanical. The ones that I have utilized throughout my career, we call them movable files. And I've used manual ones, I've used electric ones, those types of things. Purging. You purge when you run out of space or when you think you're going to run out of space. It's usually based on your readmission rate and on your need to access the health record. So, for instance, if you have 25 years of records on your shelves and you're running out of space, you may choose to take the last 15 years and purge those, meaning pull them off the shelves. If you're going to box them up and send them to storage, you can do that. If you're going to be utilizing a microfilm, microfiche company, they can come in, box those up, take them away, and do that. Or if you're going to have them scanned, somebody can come in, again, box them up, take them away, scan them. They can even scan them on site. It's just looking at when their last visit was, and you make the decision of when that's going to happen. Image-based. I'm not really sure where they're going with this slide, but paper-based storage. Sometimes if you're dealing with a hybrid record, you do have some images, and you also have the paper documents. If you are trying to take them from being paper-based and move them to image-based, which is what I'm thinking this slide is meaning to do, you will scan it, index it, and make it so that you can find the document, at least underneath a patient entry. There are file folders. They are typically color-coded, especially if you're doing terminal digit filing or numerical filing. The Numbers are usually different colors, and so it makes it really easy for you to find misfiled records. Microfilm can be a roll, a jacket, or microfiche. A roll is exactly what it sounds like. It is images that are on a roll, typically then kept in a little tiny box with a lid. If you can also have a jacket where you've got images that are placed on a slip and then put into a paper envelope called a jacket, and then you have microfiche. And again, if you're not sure what these are, go back to your textbook and take a look at those. Offsite storage, most healthcare organizations, space is a premium, and so anything for storage is offsite. And a lot of times that's been outsourced to storage companies. And again, there are pros and cons to that. I certainly wouldn't recommend it, but there are times when you can't get around it and you have to do the best that you can do. So again, it can be the healthcare organization or a commercial company. You need to make sure that they can protect the records in terms of privacy, but also in terms of physical protection, flooding, fire, inappropriate access, those types of things. But you also have to make sure it's accessible, because if those records are needed after hours, on weekends, or on holidays, how are they going to be available to the caregivers that need those? How do you retrieve and track paper-based records? You use what's called an out guide. You put it in place when you take the record out. The out guide should indicate where the record's going if you don't have an electronic system to track it. And then if you have loose material while that record is gone, typically out guides have a pocket in them, and you can tuck the loose material in there until it comes back, and then the loose material can be filed into the record itself. You may use a requisition system where somebody sends an electronic request or a paper request, and you tuck that into the out guide to indicate who requested it, when did they request it, that type of thing. Sometimes when you use an electronic requisition, it can show when you're releasing it and where you're sending it to, and when you print that off, you can put that in the out guide as well. And then a lot of times you'll have a chart tracking system, and that will be an electronic system that you can check the record out using a barcode. You typically using a barcode kind of system, so that the system itself will track where it's going, who sent it, the date they sent it, and how long it's been gone, and is it overdue, and that sort of thing. Yes, you have to organize paper-based records. You need to meet standards. You have to do a record reconciliation, making sure that you receive all the records you're supposed to receive, that they haven't been squirreled away on a nursing unit somewhere inappropriately, or in a drawer, or in a locker if it comes to that. Assembly is making sure you have all the right pieces of paper and they're in the right order. Analysis can be qualitative or quantitative, can be concurrent or retrospective when it comes to quantitative, and I'm going to refer you back to your book to get into the details of that, because I'm sure it will do a much better job explaining it than I will. However, I have done all of these things, just so you know. Monitoring completion, typically there's a deficiency slip that indicates what is missing from the record, what needs to be dictated, or what needs to be signed. A deficiency slip can be a paper-based form that you check off and attach to the front of the record, or it can be an electronic one that gets printed out of the system that shows what all the deficiencies are, and again gets attached to the paper chart. And electronic systems will keep track of chart deficiencies, and as they're completed you can update the system and all of that. But they're really looking at incomplete health records, and then after 30 days, the rule is a chart must be complete within 30 days of discharge. If not, it becomes what's called delinquent, and that means that in most cases physicians are at risk of having their admitting privileges or surgical privileges suspended if they don't get their charts done, and because they need to have charts completed within a reasonable period of time, and 30 days is pretty much the national standard. All right, correction, addendum, amendment. Corrections, typically you're going to draw a line through them. You're going to write what is needed, what should be the correct information, or if it is just For instance, if somebody put a word not in that needs to come out, they can draw a line through it, write error, sign, date, time, the correction. Or if they use left instead of right, they can draw a line through the left, they can write in the word right, and then sign, date, and time, the correction. Addendum, that's if additional information comes in later after the fact, sort of like a late entry. They can add an addendum. An example of this might be a discharge summary where a pathology report comes back after the patient's been discharged and the doctor dictates a discharge summary addendum and remarks about the contents of the pathology report and how that impacts the final diagnosis and how that impacts the patient's plan of care post-discharge and how that was communicated to the patient and what have you. And that always has to have a date on it, and it has to be signed and timed, whether you're talking paper or electronic. And then amendment, that is typically that maybe some information wasn't clear or it was incorrect and it needs to be corrected electronically, and so it's amended. Forms design. Oh, mercy, been involved with that too. You need to identify the purpose of the form, make sure it has all the necessary data on it, and that the users of that form will be involved in the development and approval process so that they understand, so that they have buy-in, that they were able to give sufficient input into what the form is and how it will be utilized and all of that. So it needs to be it needs to have unique form identification. In this day and age, that's barcoding. The barcode needs to identify the exact form it is, and then there needs to be a patient ID barcode on it too if it's going to be paper and that sort of thing. There has to be a date it was created, and then anytime that gets revised, you add the revision date, but you always keep the date created and then you add revision dates. Has to have a title, facility name and logo, patient identification information, which again, sometimes that can be patient ID barcode labels. If not, it has to have a place on the form for that to be handwritten in, that somebody writes in the patient's name, their medical record number or account number, that type of thing. And then there has to be a signature line that whoever is filling out the form has to sign it off. It has to be authenticated. And again, dates and times have to be on there. Every form has to have a date and time on it. So the content should be in the order of data entry. Again, OCR and barcodes. Now it says upper upper corner. That really depends on your system. Some systems want it in the bottom left or the bottom right or the bottom middle. So make sure if you're using OCR and barcodes, don't just slap it in the upper corner because this slideshow or your book says to do it. Make sure you're checking with IT and that you're putting it where your system and your equipment are going to find it and recognize it. Your papers, your forms should always be 8.5 by 11. It should be letter size paper, not legal, and definitely not bigger than legal. It should always be black ink on white paper, and there should be sufficient space to write. Clinical forms committee needs to be interdisciplinary because there are multiple people who need to weigh in. Pharmacy needs to be at the table. Therapies need to be at the table. Nursing definitely needs to be at the table. HIM should absolutely be at the table. It doesn't hurt to have others there as well, like IT and occasionally lab or radiology, those types of areas. If it involves a specific department, make sure they are involved in the forms committee or in the forms as they're going through that process. And then you need to have standards for forms. You need to have that it's only that the margins are here and that this is here. You always have a barcode and here's where the barcode goes. So make sure you have standards for that and that you have a sample form to provide so that people, as they're designing forms, they can see, okay, this is how it needs to be. Here's the layout. And you may actually need to give them the file that has the logo and everything on it so that they can put the insides of the form in to that template. Forms control programs, you got to establish standards, have a number and tracking system, a testing evaluation plan, check the quality of new forms, storage, inventory, distribution, and a forms database. And I would also add on here, you've got to have a plan to get rid of the old forms. you've got to be able to, when you have a new form and you're launching a new form, find the old forms and get them out of circulation, get them out of storage, get rid of them. How do you make sure of that? And how do you educate? How do you make sure everybody that's going to be using that form is equally and completely educated? So those are some things that I would say should be on the slide and aren't. So you have standards, you have monitoring, misfiles, timeliness of storage and retrieval, record completion. These are all different things that you have to monitor and review. Electronic environment, again, you want to reduce your storage of paper records. You need to have audit trails. You need to be doing indexing to make sure that forms get to the right patient, to the right encounter, to the right folder or tab, depending on what you call it, your organization. And that record completion takes place, and that work queues are being worked, and that nothing is aging out past when it should, and nothing's going to a black hole. That's the other thing about work queues. If you're working with those, you need to make sure that nothing ends up in a black hole. When you're doing your testing before your system goes live, that's one of the things to make sure is that you do enough testing and you follow through so that you don't suddenly find things going to a queue that nobody knew about. Or worse yet, not getting to any queue at all and just disappearing. Okay, so you have to have version control, because yes, you will have multiple versions of a document. It will get updated. How do you maintain all of those versions so that you know you're looking at the most current, and your healthcare providers are too? There's nothing more frustrating for a physician using a system with poor version control to find out they're using the first version instead of the most recent version with all of the updates. And then free text, there needs to be some leniency for free text, and then there definitely needs to be structured data as much as possible. Copy and paste is bad, bad, bad. Anytime you see copy and paste, you need to hiss. It is not good. It certainly helps providers in terms of getting things done a little bit more quickly, but it really kills quality and accuracy. It creates inconsistencies. It makes things longer than they really should be. And a lot of times it just takes inaccurate information and just keeps it going. So again, copy and paste, bad, bad, bad. It's one of those things that HIM professionals have to deal with and have to live with, because most places do not ban copying and pasting. So you just have to educate, educate, educate. And when you find inaccuracies, you have to bring them back to the providers to get those corrected. And I'll let you read more about that in your textbook. So another thing for electronic environment is digital dictation and speech recognition. I talked a little bit about natural language processing. All of that should be in your textbook, so I'm not going to cover a whole lot of that. Reconciliation is just making sure everything adds up, that what you started with is what you get, and that you're matching, so that, for instance, if you had a patient that came into the ED, you have an electronic ED record for that patient. Making sure that there's always that reconciliation. Emails, voicemails, EKGs, more, all those types of things. How are you going to store those? How are you going to monitor those? Make sure that they're appropriate, that they're stored, they're maintained, that they're released appropriately, because there are some organizations that have policies that you don't release emails, you don't release voicemails, that they're not part of the permanent legal medical record. And there are good reasons for that, by the way. Good reasons for that. But anyway, how are you going to handle all that? You have to know. Materials from other healthcare organizations. Way back, when I was first starting in medical records, and I won't tell you how long ago that was, because it's almost embarrassing now. But anyway, we were not allowed legally to release materials that came in from other health organizations on the patient. So let's say the patient went to System A and had a mammogram, and then went to System B, who was a competitor, and had a breast biopsy. They would send the a copy of the mammogram over, whether that was the film or whether that was the report, or both, hopefully both, and it would become part of the patient's medical record at System B. But we weren't able to release that. If somebody requested that, like the insurance company, we had to refer them back to System A, because it was their information. But that has changed. So understand that has changed. If you make it part of your record, if you're part of System B and you take that information from System A and you make it part of your legal medical record, then you can release it now. So it's the question is, do you make it part of your permanent legal medical record? If you do, regardless of where that information came from, you can release it. Then, of course, you need to search, retrieve, manipulate health data, which is called data mining, to look for trends and issues. And then you need to know how to handle amendments and corrections in the electronic environment, because it's not so easy. In the paper world, yeah, you can take a pen, strike through the left, write the word right, R-I-G-H-T, and then you can sign, date it, initial it, that sort of thing, so that you've got it. It's different in the electronic environment. You can still correct it or do an amendment for it. That's what I mean by correct it, do an amendment for it. But the system has to capture that and be aware of that. And same thing with corrections. If a nurse puts in 1,000 instead of 100, 1,000 milligrams instead of 100 milligrams, and needs to go back and correct that when she really only gave 100 milligrams, but the documentation says 1,000. How does she do that? There has to be an established process for that captures the date and time that she made that change and what the change was and that sort of thing. There has to be quality control for data entry. With scanning, you have to do scanning, and then you have to do quality control or QC and validation. You have to check on not only scanning but data entry and barcodes and transfer of data. You need to make sure that you do what's called an input mask, check drop-down boxes and check boxes and radio boxes. So make sure that you're looking at your book for all this information. And then screen design, this just goes into the things that you need to keep in mind with screen design in an electronic health record. Make sure the navigation buttons are very clear, that you've labeled the buttons and fields, you limit use of abbreviations, that you have consistent location of the navigation buttons, that you're not going all over the screen for these navigation buttons. They're always in the same place. They always look the same. How do you handle alerts, like a critical value alert when someone's level is too high and it's alerting? How do you make sure that that's clear and consistent and something that's going to catch somebody's eye? What do you do about references and checks and logical organization using neutral colors, undo buttons, confirmation buttons? Do you really want to do this before you hit delete or correct or enter? Required fields, a title for the screen, minimizing keystrokes is very important. That's one of the biggest parts that frustrates and exhausts health caregivers using electronic records, is when they have to go through multiple screens, they have to use multiple keystrokes to do something that should be quick, like a point and click, or even if you have a touch screen, a touch and move on. Appropriate field type, select from predefined lists whenever possible, and data validation checks. Identification system, your book talks a lot about this, again, about the health record number, medical record number versus an account number, and these unique identifiers, looking at whether it's serial numbering, unit numbering, serial unit numbering, alphabetic, what's a patient account number versus a health record number versus other identifiers. HIM functions include statistics, research registries, birth and death certificates, although I will say that most organizations' birth and death certificates are not done by HIM anymore. They used to be way, way back, and I have done those as well, but they have not been for a long time. That is now typically a nursing function of the specific unit. Registries, that can include like a trauma registry or a cancer registry. Those are typically done by the departments that those are in, like ED and oncology. Other registries might include like implants or tissues that are that are utilized in the OR, and the OR is responsible for those registries. So those are things that, even though they're mentioned here as HIM functions, they really aren't and haven't been for a while. But you need to know about them just as FYIs. So HIM, what are we doing? We're working with other departments. We're helping them have what they need to be able to do patient care. We're looking at information governance, making sure that information is flowing the way it needs to throughout the organization, it's maintained, really fighting for accuracy and timeliness, that entries are made at or near the time of event or care. Quality management, checking on all aspects of quality, helping with the billing or the revenue cycle process, which we'll talk about more as you go through the HIT program. And then patient registration, working with billing, patient registration for revenue cycle, and also to make sure that the information is clean as it flows through. Interdepartment relationships, we have lots of those. In HIM, we are in the middle of the cycle, and so we work with lots of people. I would say that there are next to no departments that we don't work with. We even work with housekeeping, and if you hold meetings, you'll even be working with food services. So yeah, you'll work with facilities if you have a facilities issue, something needs to be fixed. IT, definitely, quality management, patient registration, billing, nursing for sure, and patient care departments like the ED and surgery and all of that. And there are now HIM departments, for the most part, are virtual because almost everything can be done virtually. And as EHRs have progressed, there are less and less documents to be scanned. Even release of information, for the most part, can be done remotely. It's been 5 years ago now, I guess closer to 7 years ago, that we piloted doing release of information remotely, and it worked just fine. So there's definitely, and especially with PHRs, personal health records, and patient portals, which you'll study more about when you get into your second year of the HIT program, the need for on-site release of information is pretty minimal these days. So what is involved in health information systems? Release of information, chart tracking, coding, registries, billing, quality improvement. That's all in there. And we've kind of covered that and touched on that, and you will do that multiple times during the program. So even though I'm flying through it now and skipping through it, don't be afraid. You will get plenty of that. All right, and then there's also the electronic health record and personal health records, and we will touch again on those as you go through the HIT program. For now, just look in your book for a good introduction to these things. And that's really what this is about. HIT 330 is an introduction to all these little aspects of HIM. And so you're going to get little bites and tastes of it to introduce you to it. But we will dive in deep in multiple classes throughout the rest of the HIT program. So don't feel like you need to be an expert at this point. No, you just need to be introduced to it, understand what it is, and get ready to learn more. And that is it for Chapter 3. So I will be back shortly to talk to you about Chapter 4. I hope you're having a great day and a great week, and I'll see you soon. Bye.